Thank you for joining us today. My name is Dee Dee Gardner. I'm the Chief Research Officer here at the Allergy and Asthma Network. I'm thrilled to welcome you this afternoon to today's webinar. We have an exciting session, and I'm delighted to introduce you to today's speaker, Dr. Andrew White. We're in for an engaging and informative session with his extensive knowledge and experience in allergy and immunology. But first, we have a few housekeeping items before we start today's program. Our participants must remain on mute during the webinar. We will record today's session and upload it in our website within a few days. You'll be able to find all of our recorded webinars on the allergyasthmanetwork.org website. Please scroll to the bottom of the page to access our recorded webinars and any upcoming events. Next, we do have an AAN staff member monitoring the chat if you need assistance. This webinar will last 1 hour, including time for questions. You can submit your questions in the Q&A box located at the bottom of your screen anytime during the webinar. We will answer as many questions as we can before concluding today's webinar. This Advances webinar is sponsored in partnership with the American College of Allergy, Asthma, and Immunology, otherwise known as the College. The college offers CME for physicians. No other continuing education credit is provided for any non-physician. For today's webinar, all non-physician attendees will receive attendance credits and a certificate of attendance. If you would like, you can create a free college account on their website and obtain CME or attendance credits through the member portal for these Advances webinars. A few days after today's webinar, you will receive an email with supplemental information and a link to download the certificate of attendance. We will also add the link to the certificate in the chat today. So let's get started. Today's topic is managing allergic rhinitis, effective strategies. Allergic rhinitis, or hay fever, affects millions of people worldwide, leading to symptoms like sneezing, nasal congestion, itching, and watery eyes. While it may seem like just an inconvenience to some, for many, it can significantly impact quality of life, interfering with work, sleep, and daily activities. In today's webinar, we will discuss evidence-based strategies for managing allergic rhinitis, including the latest pharmacological treatments and non-pharmacological approaches and emerging therapies. It is my pleasure to introduce our speaker today, Dr. Andrew White. Dr. White is an allergist and immunologist who commonly sees patients with asthma, eczema, food allergies, other skin allergies, urticaria, and chronic sinusitis with and without nasal polyps. He diagnoses and treats common variable immunodeficiency, or CVID, and several other conditions that can lead to an increased risk of infection. Dr. White does conduct research and has published on aspirin-exacerbated respiratory disease, or AERD, also known as Samter syndrome, and chronic sinusitis. Dr. White believes in building a partnership with his patients and feels it's important to listen carefully to the patient to guide the two of them to the best possible treatment options. Outside of work, Dr. White enjoys going on adventures with his wife and children, mountain biking, reading, and making music. Thank you for being here today, Dr. White. I'll turn it over to you.
Great. Thank you so much, Dee Dee, and thank you to the Allergy and Asthma Network for setting this up. I hope that you'll all find this to be valuable. Look forward to some of the comments and questions at the end. You see here on the slide the disclosures for both myself and for our moderator, Dee Dee Gardner. And for the learning objectives, we are going to talk about the impact of allergic rhinitis on quality of life. We're going to spend some time talking about the evidence behind some of the pharmacological and non-pharmacological strategies for managing allergic rhinitis, and then we'll touch on some of the advances and emerging therapies for allergic rhinitis. So I want to start by taking one step back from allergic rhinitis, because for allergists, this the thought of nasal symptoms is something that we see in pretty much 50% of the patients that come into our practice, right? They're complaining of some sort of nasal complaint, and a lot of times they're already on treatment for allergic rhinitis, and maybe it's not working, and a lot of times that is potentially because it's not allergic rhinitis in the first place. And so we really need to have a broader differential diagnosis, because a lot of what we see ends up being non-allergic rhinitis. And so listed there on the right with the bullet points, you can see a variety of different subtypes of non-allergic rhinitis. So by definition, this is not being triggered by the typical allergic pathway. There's something called non-allergic rhinitis with eosinophilia or Nair syndrome. There's infectious rhinitis. We see this a lot in the winter, right? A patient will get a viral upper respiratory tract infection and they, slowly recover, and then they get another infection and they're just, repeatedly assaulted by that. The vasomotor and gustatory rhinitis, those are things that we see quite a bit, especially with watery rhinorrhea. And these are the patients that will say, they sit down to eat, and the moment that they sit down, their nose starts to run. That's gustatory rhinitis. And then vasomotor is often associated with other triggers, sometimes just changing in posture. So they'll say they get up in the morning, and then the first thing that happens is their nose starts to run like a faucet. They may have it with weather changes, temperature changes, getting in the car, turning on the air conditioning, et cetera. Drug-induced rhinitis, certain medications can cause this, especially in older men that are on prostate medicines. Those are well known to cause nasal congestion. There's a very difficult to treat condition known as atrophic rhinitis, where the sort of normal humidification apparatus of the nose, it becomes non-functional. There may be some alterations in the microbiome, and so the nasal passages become dry and crusted. It's painful, and it is pretty difficult to treat. And then finally, hormonal rhinitis. We know that this is something, especially for women who go through pregnancy, but in other situations. So the take-home point here, though, is when a patient comes into our clinics with nasal symptoms, they may call it allergy, but it may not necessarily be allergic rhinitis. And it's important as we step through some of the treatment. And finally, consider that these are both common conditions and they can coexist in the same patient. There's no reason why you couldn't have allergic rhinitis and also gustatory rhinitis at the same time. Okay. So we're going to move on and talk now, focus the rest of the talk on allergic rhinitis. We are talking about rhinitis, which is specifically the nose, but we know that this condition coexists with allergic conjunctivitis. And so for our patients, we should be asking them, if they're here for nasal symptoms, we should be asking them about ocular symptoms and vice versa, because many patients are going to be experiencing both. I think many patients will have one part of this that dominates, that bothers them the most. And so we're certainly going to focus our treatment towards that particular organ, whether it's the eyes or the nose. But just remember that these are going together. And I've got one other slide that hits on this in a little bit. All right, so from a burden of illness, we're going to talk for a few slides about how this affects us as humans. It is a super common problem. No doubt many of you on the call personally have allergic rhinitis. It's thought to affect about 400 million folks throughout the world. I put this triangle here to really sort of share that there's a pretty wide spectrum, I think, of how it affects us, right? Some patients may have pretty mild intermittent symptoms, and it's just a nuisance and it bothers them occasionally. And then on the other end of the spectrum are the patients that really are pretty miserable, constantly affected by this. And we're going to talk a little bit more, especially about that group. The prevalence is estimated to be around 10.7% of children, and that's including a physician diagnosis. But up to 20% of people throughout their life will report having allergic rhinitis. And we've known this for quite some time, that there's a discrepancy that seems to be stratified based on the income level of the country. And so allergic disorders, atopic disorders, do seem to be more common in patients that are more developed. So high income countries, the rates are as high as 30%, where they're lower, significantly lower in middle income or low income countries. And then when we think about male versus female, it's a little more common in boys in childhood. That flip-flops during adolescence, where it's more likely to be females, and then roughly equal in adulthood, male to female. So this, I wanted my talk to include some recent articles that are important to be aware of. And then, a lot of the talk will also be just more of an overview, but this is one of the papers I thought was important to review. This is a really cool study it looked at a technology called Mask Air. So Mask Air is an app that the users would have on their phone. And basically what it would do is prompt the user with allergic rhinitis to enter in answers to questions that both related to control of allergic rhinitis and also the effect of that the effects that the patient was having related to work productivity. And this all comes down to the fact that when you have allergic rhinitis, you don't tend to miss work from it, but you do tend to go to work and not function like you should. And that's called presenteeism as opposed to absenteeism. So this study was really designed to look at the effect of allergic rhinitis, specifically poorly controlled allergic rhinitis, on presenteeism. So this study occurred in about 22 countries around the world. The individuals that participated would, go through for several months, rating their symptoms and then how it affected their school or their work. And you can see that the patients were then stratified on a weekly basis to whether that week was well controlled, partially controlled, or poorly controlled. And then the app and the analysis was able to look at the effect on work productivity. And then this was all normalized to US dollars with the purchasing power. So the dollars we'll talk about are based on US dollars. Not a big surprise here. I'm sure you saw this was coming, that if you have poorly controlled allergic rhinitis, it has a significant effect on work productivity, and much more for patients where it's poorly controlled versus if it's well-controlled allergic rhinitis. So you see the spread there. The red is the poorly controlled, and then on the opposite is the green, the well-controlled. So poorly controlled allergic rhinitis had up to a 60% effect on productivity. And what that means in a dollar amount is about $500 per week per patient in lost productivity in US dollars. And so this is huge. I think, large companies probably recognize this when they think through the productivity of their workforce. And that's why there's often a lot of, programs to help promote wellness, both physical and obviously, psychological wellness, but in this case, physical wellness. And so we would, do well as physicians to recognize that this poorly controlled condition really can have a significant effect on society at large and then on our patients specifically. Okay, so a couple take-home points. No surprise to you on the line, but allergic rhinitis, it's not just about the nose. We think about a variety of other components of this disease. We know that it can really affect sleep. And so in a study here that demonstrated that about 1 out of 5 patients had excessive daytime sleepiness, and over half had poor sleep quality associated with allergic rhinitis. And then when we think about cough, upper airway cough syndrome, our patients can be more prone to prolonged cough or chronic cough. This study looked at capsaicin, which is a way that you can trigger the cough, and you can find it's sort of like a methacholine challenge where you can find the exact level that triggers a specific cough reflex. And so these patients, if you did that challenge during the pollen season, were much more sensitive to capsaicin compared with being out of the season. So, clearly, and there's lots more studies that we could go over, but this is not just a syndrome of nose and eye allergy symptoms that has far-reaching consequences. And this is one more study that I wanted to share. This was a really, I think, an interesting observation. So the authors were looking at something called keratoconus. And what keratoconus is it's a elongation and abnormal shape of the cornea. It's thought to possibly be because of chronic eye rubbing. And what ends up happening is the cornea now becomes thinner. And because it has this abnormal shape, it's going to have effects on vision acuity. Patients may have increased sensitivity to light and glare, and they may be much more frequently needing to get a prescription changed. So this has been thought to be associated with allergic disease in the past, specifically atopic dermatitis, but it has been a little bit less clear whether this is also just related to allergic rhinitis. So this was a big meta-analysis that looked at a huge number of patients, and they were looking at the rate of keratoconus in patients with allergic rhinitis. And so here you can see that there's a significant association with an odds ratio of 1.7 for having this condition, this keratoconus. So I think as allergists, we tend to be a little more uncomfortable with ocular symptoms, especially anything that's sort of outside of the typical allergic conjunctivitis um, symptoms. But we really need to understand that this is associated with our disease that we treat, both allergic rhinitis, also some of the other conditions that we treat. There may be a component of this being caused or triggered by chronic eye rubbing. And so this has big consequences for our patients. So if we have any, I think, suspicion that this could be going on, we should consider early referral to ophthalmology for evaluation. Or if the patients are not thinking to tell us about this, maybe asking a few questions about if they're noticing any change in visual acuity. All right. Couple more just introductory slides. This is just, if you're not familiar with this paper, it's a really great paper that looks at really the rise of allergic disease over the last 150 years or so. Everyone has a lot of interest in this. Why are we seeing such rapid changes in the development of all of our atopic conditions? And we see really that, it's around 1870 is where a lot of the modern thought about the beginning of allergic rhinitis. There's certainly reports of it going on before that, but that's really sort of when this epidemic of allergic rhinitis began. And in the early 1900s, it really was mostly just about allergic rhinitis. And then following that, we started to see, increase in the rates of asthma and then the food allergy and even these newer syndromes like eosinophilic esophagitis and alpha-gal allergy. There's a lot of really interesting theories about how this happens. You can see on this, it's a great article that talks about, a variety of different changes to our environment, like the chlorination of water, ragweed eradication, and things like that are just interesting from a historical standpoint. All right, so we'll get into the meat of it here. For allergists should be intimately familiar with this concept. This cartoon uses food allergen, but the premise is exactly the same for an airborne allergy. So we'll just switch that out to say dust mite. And what happens is you have initially encountered the allergen on your mucosal surface or your epithelium. That's going to be met at some point with a dendritic cell. The dendritic cell has to understand that that allergen in this specific context is something that is abnormal and merits a response. And in this particular situation, when it's allergy, the dendritic cell will introduce the allergen to the naive T cell, and that context will lead to the development of a Th2 cell, and these are defined by the cytokines that they produce. Why this happens is still an area of hot research. If you could shut that off and prevent the development of allergy at the very beginning, that would be a big advance. But we then end up with these important cytokines that are being produced, like IL-4, IL-5, IL-9, IL-13. The T cell then is going to interact with the B cell in the lymph node. And then again, with this specific context of these cytokines, the B cell will differentiate into a plasma cell that makes IgE, in this case, IgE against dust mite. Those IgE molecules or antibodies will then circulate. They will find the mast cell where they will predominantly cluster on the surface of the mast cell. And now these mast cells are back at the areas of interface with the external environment. And so now at a later date, with the allergen being introduced again through the mucosal surface, now the mast cell is primed and it will cross-link IgE and release, and you get that immediate response. So this is the classic allergic pathway. It's a very sophisticated loop from a immune standpoint. And we're going to circle back a little bit to this at the end when we talk about immunotherapy. All right, so we're going to now talk about treatment. When we go through with our patients the ways to treat, I really try to make it clear to them that everything's going to fall into one of these three categories. We can help them identify and potentially avoid the allergen. We have a variety of medications that I'll talk about, and then we have ways that we can modify the immune response called immunotherapy. So everything's going to fit into one of these categories, and I think it's important that we go over with the patients what's their main goal here. Are they mostly interested in avoidance? Are they mostly interested in medication? Or are they really interested in immunotherapy? So each one of these slides really could be a talk in and of itself. So I'm giving you a lot of this is just giving you some broad overview. One of the main allergens that we encounter is dust mite allergen. We know that's a huge driver of allergic disease. And there's a variety of ways that we can control dust mites, focusing mostly on the bed. So mattress encasements, these are, very tightly woven encasements that can prevent the passage of the dust mite allergen through them. And so you're able to dramatically decrease the amount that's actually going to be exposed to the nose or in breathing. HEPA filters on air purifiers can potentially be helpful. There's opportunities to address the carpeting when vacuuming. Again, you could use a HEPA filter. And then humidity control. So the more humidity, that's potentially going to foster more dust mites. And so a dehumidifier potentially could be helpful. There's some pros and cons to a lot of these things. And, it's justifiable to also really want to see, just because you can do an intervention to decrease the dust mite count, does it really lead to an improvement in symptoms? And so I think we need to be cautious as we counsel our patients that we don't go overboard telling them to do everything, but we do want to give them some tools to make a difference in their home environment, especially for dust mites, where there's definitely evidence that these controls can help improve symptoms. Okay, so some of the other allergens. So cockroach is another important one. Many of us test for this. And unfortunately, it's just not really clear how much benefit there is from avoidance measures. I think most people who, if they have a cockroach infestation, they're probably going to be interested in getting that remediated. But whether that alone is going to lead to improvement in symptoms is less clear. Some interesting statistics here about pet allergies. So only about 4% of sensitized individuals will remove pets from their homes. So this is not a popular answer when we tell them, yeah, you're allergic to cat. How do you feel about removing the cat? So unlikely that that's going to change their approach. And I honestly think that sometimes that's why patients come in, right? Because they are having symptoms, they have a pet that's part of the family, and they're unwilling to, consider removal of the pet. Because a lot of the allergen with pets is pretty sticky, so it's really more on surfaces and less so just in the ambient air. It's a little less clear that HEPA filters will have a huge effect. If you one of your plans is to wash the pet, there's some studies that show that you need to wash it at least twice a week to minimize the allergens significantly. And I think that's a harder thing to do on a regular basis with that goal in mind. And then what about pollen? I think this is interesting. We don't have a ton of evidence for many of the things that could be done for pollen allergy. Some of the things that can be done are special filters that you could put in your car or the home, so you're filtering the air, keeping the windows and doors shut, and so you're able to potentially decrease the pollen count somewhat inside the house. Some other recommendations that I think are interesting is washing your hair and clothing before entering the bedroom during heavy pollen seasons. And then there's actually that's not what the photograph is here, but there are some special glasses that are wraparound and even nasal filters that have been studied that have been shown to be somewhat effective. So there are some interesting potential advancements in that. I'm not sure exactly the appetite of patients to be doing that, but at least those are out there and you could be aware of it. So those are the avoidance measures. Now we focus on medication. And I think this is a really challenging area for us as physicians because a lot of these are available over the counter. So the patients will have already potentially tried these things. They may not show up in the medical record. They may not remember. They say, I took a nose spray. So it's the green one. And they're like, okay, well, that's I'm not even quite sure what you took, and now you're telling me it didn't work, but I don't even know what it was. And so I think it's a big challenge here. There's also the possibility that patients can be on combination medicines. And again, they're doing this a lot of times on their own or based on the advice of friends. So that's the challenge here. Here's the lay of the land. So we have pills. So the oral agents are going to be the antihistamines, and then the other drugs that could be used that are easily available are the cystidyl-leukotriene antagonists. So that would be montelukast. It's one of the more common ones. We've got some ocular products, so antihistamines, mast cell stabilizers, NSAIDs actually. The topical NSAID has approval for allergic conjunctivitis. And then corticosteroids, especially the low potency ones, can be used for a period of time relatively safely, even though we generally like to have ophthalmology involved in that. And then we have the nasal products. You're all aware of these, the nasal corticosteroids, the nasal antihistamines, there's nasal mast cell stabilizers, and then there's some products that are combinations, specifically steroid antihistamine nasal spray combination products. When we see a patient, we will try to sort out whether this is more of an intermittent issue, and then also whether it's severe or mild, or is this persistent, right? And a lot of times the patients will have a little bit of both. They may have like a season that's particularly bad, but they were congested all year long. And the point of this slide was really to show, that there's a lot of options and they're all pretty fair in terms of your first try. But one of the treatments that can really be effective for all of these is the intranasal corticosteroids. And when you compare these against a lot of the other treatments, it's a really good place to start. There's obviously some pros and cons to all of these. And so our job is really to go through with the patient and try to understand, what are you looking for out of a medication? Do you want something that's maybe a little bit more of a long-term way to control this? Or are you just looking for what you can take, twice a week, twice a month when you're having a bad day? This review went through a lot of the evidence for the various products that are available. And I wanted just to highlight, I don't like to include big long tables. I know it's hard to get oriented here, but I just want you to scroll through down here with the onset of action of these medications. So this is, I think, really important as we're giving advice to our patients. And you can see that the products that really seem to have the fastest onset of action, within 5 to 15 minutes, are really going to be the topical antihistamines. And so here's azolastine, or the azolastine fluticasone combination products. The oral pills tended to be more delayed in the course, over the course of a couple hours. And then the other thing I think that I would want you to pay attention to here is that the nasal steroids actually do have a relatively quick effect. I think we tell our patients, you're going to start a nasal steroid spray, you're going to use it for, a week or two to really get your max benefit. But there's actually benefit in these different challenge studies, even over the course of a few hours. And so you can see here that down here at the bottom that, there's evidence that the nasal steroid sprays can work over the course of, 6 or 8 hours. So even within the first day of use. But this really speaks, I think, to how we can counsel our patients if they're wanting something that works immediately and just something to take occasionally. That's going to be a little bit of a different recommendation that we can give them versus if they're using something a bit more regularly. This was a network meta-analysis that compared the nasal products all to themselves. And so this is a way to, look at the magnitude of effect. The way that these are structured is the size of the circle is the number of patients. So you can see how big the studies were. And then the intensity of the green versus the red is really the magnitude of the benefit. So you can see that when you compare these all to themselves, the fluticasone products seemed to do very well. The nasal steroid sprays generally seemed to do pretty well. And then the nasal antihistamine sprays, olopatadine and azolastine, had really sort of a less strength to that response. So you could see more orange and red there. And then the combination products, makes sense that those combination products also did well. So the take-home point here, though, is that the nasal steroid sprays probably have they're superior in terms of the benefit that you're going to get compared directly against the nasal antihistamine sprays. A lot of our patients are going to be using combination products. And so this is a summary that came from a very large review of all of the treatment options for allergic rhinitis. These are some statements that came from this. So for oral decongestants, the recommendation is not to use these routinely. The combination of using an oral antihistamine and a leukotriene receptor antagonist. So we need to be careful about this because of the leukotriene receptor blocker. We know that those have a black box warning now related to mood. And so we need to be really careful about having that be part of first-line therapy at this point. So that would not be a combination for first-line therapy. The recommendation here is that if you're using a nasal steroid and a nasal antihistamine combination, that's a really strong recommendation to use this when the nasal steroid alone fails. It's a good addition. And there's strong evidence that the nasal version is better than the nasal steroid and the oral antihistamine. So if you're stacking those against each other, better to go with nasal steroid and nasal antihistamine. Again, when you're thinking about nasal steroid and a leukotriene receptor antagonist, you're dealing with the black box warning. And then intranasal steroid and a nasal decongestant. So this is interesting. We know that there's the big concern with the nasal decongestant is the risk of tachyphylaxis. And there's several studies that can reassure us that if you're using a nasal steroid spray along with that, you have a significantly lower risk of developing tachyphylaxis. And so I think it is, it is an option. It's probably superior to the nasal steroid alone, but you do still have to counsel your patients about the potential risk of tachyphylaxis. And then finally, for patients that have a really strong rhinorrhea component, there's not much evidence for combination with nasal steroid and ipratropium, just one study. This comes up a lot for natural treatments. A lot of our patients are interested in something other than medication, and we could tell them that for acupuncture, there does seem to be some benefit in quality of life. It can be considered. The other very common things that people are interested, like local honey or herbal therapies, we just don't have evidence to support them. So we can't really give a recommendation that's evidence-based. Be good to have more studies to see if there's really something there. So at the end of all of this, we've got a lot of treatments. Many of them are over the counter. The patients are often left to their own devices. And I think for a lot of patients, if they're going to any doctor other than an allergist, this might be a 20-second recommendation as part of a bigger visit that includes hypertension and diabetes management. And, so they're not getting a lot of good education. So these are some summary statements that I think are really interesting. This is coming out of a big evidence-based review article on allergic rhinitis. So number one, patients are poorly adherent to treatment. There's no doubt in my mind, based on my clinical experience, that is true. The number three here is that most patients with rhinitis use on-demand treatment when their symptoms are suboptimally controlled. So that means that despite still having symptoms, they're just taking medication when they're having a particularly bad day. And then when they're really uncontrolled, they change their medications to daily. So they're sort of living with symptoms that they could do better with. Number four, the vast majority of patients do not follow guidelines or physicians' prescriptions. And then this next one is my favorite. So when physicians are allergic, they behave like patients. So even though we know better, we know how best to manage this, we still end up doing the same thing. We wait till we're particularly symptomatic, we take medication for a few days, and then we stop, and we never really satisfactorily achieve control. And so this really suggests that we need to, sort of overhaul the way we even think about this in terms of educating patients, because the way that we're doing this, if we can't even do it ourselves as physicians, we're hard pressed to expect our patients to do it. Okay, so those are the medications. There's a lot more to go over in that area, what I tend to tell patients is, for most people, we can probably get the bulk of their symptoms under control with medication, but not everybody. And in some patients, the bulk of the medications that would require them to take to be under control is not really a satisfactory option. They're just not willing to do that. And so there's lots of reasons patients are interested in moving towards immunotherapy. So this would be the treatment that we could offer that's going to modify the immune response. So immunotherapy is something that has been done for decades, and for a long time, although it was clear that it worked, it was not clear exactly whether it would have a disease-modifying effect. Because ultimately, what we would hope for a treatment is that you would deploy it for a certain period of time, and then this modification to the immune system becomes permanent. So this was one of the main landmark studies that looked at this. So Dr. Steve Durham published this in the New England Journal of Medicine in 1999, and all allergists should hopefully be really aware of this paper. So there was a group of patients that got placebo shots, placebo immunotherapy, and then a group of patients that got active treatment. And you can see here in the far left column, the pollen count on top is in green, and then below that are the patient's symptoms. And the patients that were on placebo had a lot of symptoms. The patients that were on active immunotherapy had a significant improvement in their symptoms. But the study really was designed to follow what came next. And so now, in this particular trial, they then changed the patients in the active group, the patients that were getting the immunotherapy in yellow. They were randomized to either discontinue shots or continue their maintenance shots. And the big question was, what would happen if you discontinued your shots? Would you start to have symptoms again, or would you continue to do well? And so when you look across these subsequent years, 1993, 1994, 1995, you can see that the red and the blue groups really are superimposed with each other. So there was no advantage to continuing the immunotherapy at that point. So you might as well stop. And the great message here is that with immunotherapy, at least the way that they did it in this study, there was a permanent effect that you could modify the immune response. And so you would be able to stop your immunotherapy. And so this is why we have the recommendation for our patients that our goal of treatment is going to be a 3 to 5 year time frame. And then we would consider discontinuing at that point. And at that point, recommend that the immunotherapy has really done its purpose. So how does immunotherapy work? We still are trying to figure that out after all of this time. And so this is that same path that I showed you before with the dendritic cell talking to the T cell. The T cell is differentiating into Th2 cells, ultimately making IgE. That's across the top. And across the bottom is what potentially is happening with immunotherapy. So you're stimulating the immune system either subcutaneously or sublingually. And there's a variety of effects that have been measured over the years. And the cumulative effect is still unclear, but there's the development of regulatory T cells. There's the proliferation of some anti-inflammatory cytokines or immunoregulatory cytokines like IL-10 and TGF-beta that you see there across the bottom. You're also going to change the antibodies you produce from IgE to IgG4, and that potentially can have an effect on sopping up some of the allergen. So there's a lot of effects here that are interesting that we're still learning about. And the more we understand about this, the better we can hijack this process and make it safer and more convenient for patients. So, but this is the rationale for why immunotherapy works. There's several ways to do immunotherapy. I've outlined the three most, universally used here. So at the top, we've got subcutaneous immunotherapy, then sublingual immunotherapy tablets that are available as prescription, and then sublingual immunotherapy drops. And I'll quickly go through the differences. So for the shots, the subcutaneous across the top, We really are, we've got good data for a lot of the allergens, not for all of them, but what the therapeutic dose should be. There's a risk of anaphylaxis, and so the shots have to be given in the office. And there's a different cost structure associated with this. Immunotherapy given as a shot is not a pharmacy, doesn't come from a pharmacy, so there's not going to be a pharmacy-related copay. There'll be different CPT codes that go through the deal with the costs. All right, so then sublingual immunotherapy tablets. And so these are FDA approved. Each one of these went through rigorous double-blind placebo-controlled trials. And so we've got great evidence for the effect of these. Because these are safe, they can be given at home. And so these are daily treatments. The first dose is usually observed in the office, and there's a theoretical risk of allergic reactivity to it, but because of the relative safety, these are given at home. You start off at the first dose you start off at the top dose. So there's no updosing, which is different than shots where you have to gradually increase the dose. Because these come from the pharmacy benefit, there can be copays and there can sometimes be challenges getting it approved. Some of the other difficulties are that we don't have many options for these particular. So we've got grass pollen, dust mite, and ragweed. So we have some limitations in patients with multiple allergies. And there's also some questions about, using these together, just in terms of the logistics of, treating both grass pollen and dust mite together in the same person. And then finally, there's these slit drops. And so these are really used by using the allergen extracts. These are created for a patient based on what they're allergic to, and then they could be administered as a sublingual drop. These are not FDA approved. They're generally not going to be covered by insurance. Because it's using the sublingual route, there's a lower systemic reaction risk. And there's less certainty about the clinical benefit of these. As in subcutaneous immunotherapy, there's a pretty wide range of what can be put in the dose in terms of the amount of allergen. And so that leaves some uncertainty in terms of what we can tell our patients regarding the clinical benefit. Okay. These are meta-analyses that are looking at the two main options, so subcutaneous immunotherapy versus sublingual immunotherapy. And you can see the main point here is if a patient asks us which one is better, they both work. Subcutaneous works, sublingual works. This is looking at symptom scores and medication scores. So clearly, these analyses favor either one of these options, subcutaneous and sublingual immunotherapy. So it gives us as physicians the luxury of also going through some of the logistics and patient preference as we decide what we're going to deploy for the patient. Don't try to read this. I just wanted you to see that this table exists. So this is from a very large review of treatment options for allergic rhinitis published in the journal IFAR in 2023. And I'm just going to scroll down and just show you what's there for. This is the bottom line related to immunotherapy. So these are recommendations from the authors after going through all the evidence and trying to come up with some general recommendations. And so you can see here that under strongly recommended treatment options are subcutaneous immunotherapy, sublingual immunotherapy with slit tablets, and then specifically because there's better evidence for tree pollen, the slit drops. Recommended would be using high-dose slit drops for some of the other, something else, a mold alternaria, and then using two different tablet sublingual immunotherapies. Then some options, we have different ways to get patients to maintenance, and so rush versus cluster, because there's a little bit less evidence, the slit drops for animals. And then there's actually some innovative ways to administer the allergen that are still undergoing study, but there are some places that do offer this. So intralymphatic, where the allergen is actually injected directly into the lymph node. And there's also oral mucosal immunotherapy, which is considered. And then there are some other potential ways to administer immunotherapy, and none of these are standard and not recommended. You see them listed there. I'm not going to spend more time talking about that. If you treat allergic rhinitis or see patients with this, you really need to be comfortable with this concept of pollen food allergy syndrome. A lot of patients will have this and may even come in complaining about this as their primary complaint because of a food allergy. So there's an array of foods that cross-react with the allergen that's in the pollen. And when you ingest that food, especially in the raw form, you'll end up with oral mucosal symptoms. We used to call this oral allergy syndrome. Now the preferred term is pollen food allergy syndrome. And so you can see here with birch pollen, patients often would have this with apple. They may have it with carrots. For ragweed, we see bananas, cucumbers, and melons. Grasses have a lot of those same foods. Mugwort is sometimes called mugwort celery spice syndrome, and you see there's a lot of spices there. So if the patients are coming in complaining about a variety of food allergies and they're foods that are listed here, you do well to actually do a bunch of pollen allergy testing and help them understand the cross-reactive patterns. For most patients, these foods only cause problems if they're in the raw form, and if they're cooked, they tend to be well tolerated. So for example, a patient, might be able to eat carrot cake, but not have a raw carrot, or have apple pie and but not be able to eat a fresh apple. This is an evolving area that as allergists, we need to be aware of this. So can you have allergic rhinitis with negative tests? So this is a concept called local allergic rhinitis. So you would have a patient who has suspected allergic rhinitis. You would, you've got our main tests, which are going to be the skin prick testing and the serum IgE testing. And basically, for either one of these tests, if you go down and you make it all the way to the bottom and you've got negative skin testing and negative serum IgE, and maybe you have a really strong suspicion based on the clinical history, maybe it's with dog or with cat or something along those lines where it's really clear, then you could do a nasal provocation test. And there are now protocols for how to do this. And this is important because there is a subgroup of patients that clearly have this condition where they have a reproducible allergen positive provocation test. They have negative testing. And we know that in this group, they can respond to immunotherapy and avoidance measures. And so in terms of thinking about patients who may be interested in immunotherapy, if you can prove the allergen with the nasal provocation test, then that is something that's an option for them. So if you're interested in this, there are some articles in the literature that describe how to do this. And so just be aware that this is out there. And for patients that have a really strong history, we should be considering doing this, I think, a bit more. I will finally finish with this slide. So when patients come to the office with allergic rhinitis, once we've diagnosed them with allergic rhinitis, we have clearly defined that they have an allergic condition. And these are conditions that often coexist with other allergic problems. And so we should be asking questions or thinking about some of the other things that go along with allergic rhinitis. So chronic rhinosinusitis is one important one. Patients can have overlapping symptoms. They may still have a lot of postnasal drip or nasal congestion. And if you just approach it from the standpoint of allergic rhinitis and you don't ask questions about sense of smell or purulent discharge, you may miss the fact that they also have chronic rhinosinusitis, with the treatment would be different. We should be asking our patients about whether they have any reactions to aspirin or NSAIDs. So patients with a specific form of chronic rhinosinusitis with nasal polyps will describe having nasal congestion, sneezing, and rhinitis if they take an NSAID. And that would be treated differently. It usually signals that they have underlying nasal polyps. Patients very commonly have comorbid atopic dermatitis, and especially for the patients that have a lot of ocular symptoms, there can also be a component of periorbital dermatitis that may be really affecting their vision and their ocular symptoms and coexists with allergic rhinitis. especially when patients are having GI symptoms, especially if they're having any dysphagia symptoms. We want to ask about eosinophilic esophagitis and consider working them up for that. Up to a quarter of eosinophilic esophagitis patients actually have pollen food allergy syndrome. And so that should be another thing that should just raise that in the back of your mind to maybe ask a few questions about whether the patients feel like they have trouble swallowing or food gets stuck. Obviously, asking questions about food allergy, prompting questions about foods that make the mouth itch that are related to pollen food allergy syndrome. We know from the unified airway theory that what happens in the upper airway can often go in the lower airway. And so asking about cough, wheeze, chest tightness, asking the patients how they do with a viral illness, all really important. And then remember, like I said at the very beginning, a lot of these patients may have a component of non-allergic rhinitis, and they may do really well with ipratropium nasal spray for the rhinorrhea component of their non-allergic rhinitis, while you're also treating simultaneously their allergic rhinitis. And so the summary here, I think a couple things. Number one, probably we don't need to tell allergists that they need to take this condition seriously, but we do need to be able to properly educate our peers and other specialties that these patients can have a significant effect on their quality of life. And there's more to this than just telling them, in 30 seconds to go take some over-the-counter medicines, because this can be affecting their sleep. It can be causing them to have cough. We know that it can have effects on visual acuity later in life if they develop keratoconus. It can have a lot of issues with presenteeism. The second point is that we've got a lot of different treatment options. This is, classic area for shared decision making and really sitting down with the patient. What exactly do you want? Let's find something that works for you. Me just telling you to take something daily isn't a great treatment for you if you're not going to actually do it, if that's not what you want. Giving patients good information about their sublingual, their immunotherapy options, whether it's sublingual or subcutaneous. And then don't forget, we have this opportunity when we're talking about their nose to also ask about the other comorbidities and see if there's some other ways that we can tune up what the patients are experiencing medically. And with that, I'll pause, and I'm happy to take some questions.
Perfect timing. So we have a couple of questions that people are interested in treatments for children or adolescents. Do you have suggestion or recommendation that you've seen, or based on your experience and research, that would be more beneficial for children or adolescents?
So so almost everything we've talked about is available for children and adolescents. So the sublingual immunotherapy, subcutaneous immunotherapy, pretty much all of the nasal treatments, the oral treatments, it's all options for children and adolescents. I think I find that, the issues with adolescents is they're slowly developing their own personality, and there's often a bit of conflict between what the patient wants and what their parent wants. And so I'll often really try to engage the teen themselves, like what do you want out of this visit? And often encouraging them to do something regularly, like a nasal corticosteroid spray. So if you look at all the data, nasal corticosteroid sprays are usually going to be the winner. And so if I can convince someone to do that, even if it's just, a couple times per year when they're really bad, and then they do that for a couple weeks to calm things down, I still feel like that's a win. A lot of times people are, taking oral antihistamines and they're not getting a lot of benefit. And so that's the real opportunity to try to switch them to a nasal treatment. For the younger kids, I think it's a little more challenging because getting a nose spray in can be challenging. So trying to get a little bit of an engagement with the child, just to, like at that visit with their parent there, get them on board with the fact that this is going to help you the most. But the story is still the same. The nasal steroid sprays, if you can do those regularly, are going to probably be the winner.
Yeah, thank you. Then we also have questions. A couple of people have asked questions specific to nasal saline and nasal washes. Do you have recommendation for these?
Yeah, so that's a great treatment option. I think we tend to use that more in patients with chronic rhinosinusitis, where that is really a defined treatment. And the difference here is a nasal saline spray is just a small volume spray, similar to, like a fluticasone nasal spray, but the rinse is a large volume. And so you're instilling a large enough amount of saline into one nostril that it actually goes around the back and comes out the other side. So they were all familiar with the concept. And so that's great for patients that are prone to recurrent infections. They got a lot of thick drainage that they can't clear out.
Mhm.
The many patients who use this just really like it. It has a natural decongestant effect. And I think that's a really great treatment if it works for a patient with simple allergic rhinitis. The problem is true nasal rinses are pretty messy. And so and they depend you have to have clean water and it's not super fast. And so there's a nuisance factor to it.
Mhm.
But so absolutely, I would tell a patient if you are interested in trying this, let's do it. And if you like it, it's a great treatment to consider.
And then our last question here is dealing with immunotherapy. Could you speak to the intervals for retesting after starting immunotherapy or over time using immunotherapy?
Yeah, so if you're going to go on immunotherapy, we're expecting there's going to be some changes in your allergy profile.
Mhm.
The 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 truth is, we're not going to base decision making on stopping the immunotherapy based on the size of the test. So, many people won't repeat testing simply
Yeah.
with the purpose of telling the patient that they can now stop. I think the evidence is really strongest that you just do it for a 3 to 5 year period of time and then you stop. Um,
Mhm.
the I think the reasons sometimes patients they are interested in repeat testing, and I think that's reasonable. It's also very reasonable if there's been a change in symptoms and you're wondering if they've developed a new allergen.
Mhm.
Um, but I don't think it's really necessary to just de facto test everyone at the 5 year mark in order to determine whether they can stop their shots.
Mhm. Yeah, that patient education for immunotherapy, the commitment, definitely needs to be discussed with the patients to get them to the finish line, trying to finish that
Yeah,
out.
there's probably 20 to 30% of patients don't complete immunotherapy. It may be higher in different groups. And that's a huge problem because a lot of times the patients will come in and they had a bad few months. That's why they're here. And they're sort
Mhm.
of willing to do anything. And I do think we need to really say like, you really need to think through this. Like I understand you had a bad couple months, but this is a really big commitment. Let's really talk about what that means in real life. Exactly.
Yes. Exactly. Well, we thank you, Dr. White, for your exceptional presentation today. We really have learned a ton. For the attendees, remember that Zoom will email you in a few days with the link to the recording and an evaluation with supplemental resources. What's on the horizon is we are thrilled to share that we'll have 2 exciting webinars coming up that we hope that you will join us. One is on March 27th at 4 p.m. We invite you to join us for the Unidos Hablemos webinar series offered in Spanish. This will be focused on eczema care in the Hispanic Latino community, more than what you see. In this special session, Berenice Alberto will share, she's an eczema patient and will share her journey living with eczema, offering a heartfelt look at the daily challenges she faces and the impact that this disease has on her life. Her story will be sure to inspire and resonate, providing valuable insights into the emotional and physical aspects of living and managing this condition. We hope you'll be able to join and connect with us during that conversation. The second is on April 10th at noon. Please join us for another Advances webinar. This one is titled Basics of Biologics, presented by Jared Devereaux, who will provide a comprehensive overview of the biologic therapies, their development, mechanisms of action, and the wide range of conditions that biologics are designed to treat. Don't miss the opportunity to enhance your knowledge and stay current on the latest advancements in our field. Thank you once again from all of us at Allergy Asthma Network. We strive daily to be your trusted resource for people with allergies, asthma, and related conditions. Thank you.